I am Dr. Charles Faiman, the chair of the virtual Grand Rounds sessions on type 2 diabetes. I am a former chairman of the Department of Endocrinology, Diabetes, and Metabolism at the Cleveland Clinic and currently a consultant in the department. I am pleased to welcome you to this fourth session of the current series on type 2 diabetes, an educational program sponsored by the Cleveland Clinic. As with the prior presentations, we will follow a case-based format. We already have heard about the pandemic of diabetes in the United States and globally. Also, we have been provided with preventive and management strategies. Today's session will discuss the management of type 2 patients with the common problem of concomitant chronic kidney disease. Most importantly, adjustment of treatment regimens in the face of compromised renal function will be addressed. I am pleased, therefore, to welcome our speaker today, Dr. Adi Mehta. Dr. Mehta is currently a staff physician in the Department of Endocrinology, Diabetes, and Metabolism at the Cleveland Clinic. He is a former professor in the Department of Medicine at the University of Manitoba in Canada. Dr. Mehta is a knowledgeable clinician, having been honored in the past with the Clinician of the Year Award by the American Association of Clinical Endocrinologists. He is an accomplished researcher and gifted speaker who is frequently asked to speak at local, regional, national, and international gatherings. Dr. Mehta.
Thank you for giving me this opportunity to share the next hour with you. We're going to be discussing diabetes therapy in patients with type 2 diabetes and kidney disease. And this is a very significant topic that needs some elucidation, mainly because a lot of the medications that we're so used to using in diabetes are not necessarily indicated or can be used with liberally in the context of kidney disease. What I'm going to do over the next few minutes is, using a case-based approach, we will discuss the appropriate treatment goals for type 2 diabetes in patients with chronic kidney disease, and most importantly, the appropriate glucose-lowering agents in such patients, and the safety and efficacy of these agents when faced with the patient with chronic kidney disease. So here's the case. This is a 63-year-old African-American gentleman with a 15-year history of hypertension, for which he is on atenolol and hydrochlorothiazide, and his blood pressure is moderately controlled at 144/83. He also has hyperlipidemia, for which he is on a statin. His HDL is low at 38, and his LDL is controlled in that it is less than 100. He recently was diagnosed with diabetes. His BMI is 33, so he clearly has a problem in terms of the fact that he did not achieve his ideal height for his weight. And his hemoglobin A1C is clearly abnormal at 7.1%. Obviously, we make a diagnosis of diabetes when the hemoglobin A1C is over 6.5%, or if the fasting sugar is greater than 126 milligrams per deciliter. The renal parameters in this gentleman, who already has hypertension, shows a serum creatinine of 1.53 milligrams per deciliter and an estimated GFR of 63 mils per minute. He does have albuminuria, and his albumin creatinine ratio in his urine is 70 milligrams per gram of creatinine. So, when we look at the guidelines for treating patients with newly diagnosed diabetes, we have two major guidelines in the U.S. The first is the ADA-EASD position statement in managing hyperglycemia, and you'll notice that the recommendation is you start with lifestyle changes and metformin. If over a period of 3 to 6 months you do not achieve the goal hemoglobin A1C, which would be less than 7%, then you consider adding on other therapies. And the ADA-EASD statement gives you the option of starting any one of the major groups of anti-hyperglycemic agents. sulfonylureas, thiazolidinediones, the DPP-4 inhibitors, the GLP-1 receptor agonists, or insulin itself. The choice, according to them, is based on the answer to 5 crucial questions. How much efficacy do you need? Meaning, how much of a lowering of hemoglobin A1C is required? How much risk are you willing to accept from the point of view of hypoglycemia? How much weight issues are you willing to accept? And obviously, the side effects of the different medications are different, and we need to take those into consideration in the context of the patient. And finally, the cost. I would put it to you that unfortunately, at present in the U.S., cost seems to drive the choice much more than any of the other considerations, which I think is a real pity. But be that as it may, these are the 5 choices we have. If after 3 or 6 months we have not achieved goal, the recommendation is to then add on a third agent. And obviously, depending on which one you used as your second agent, you are welcome to choose one of the other agents. And then finally, if all else fails, you go on to a multiple daily dose insulin regimen with or without the sensitizers. That's the ADA-EASD position. The American Association of Clinical Endocrinology position is, in my opinion, very much simpler and much more practical. They basically tell us that when you make a diagnosis of diabetes, you obviously will start or implement lifestyle modifications. But then depending on what your initial hemoglobin A1C is, you could make your choice of therapy. So if your initial A1C is less than 7.5, any agent used in monotherapy would give you benefit. But if, on the other hand, the hemoglobin A1C is greater than 7.5 but less than 9, there is a very, very strong indication that you will need early combination therapy, and the recommendation is you add whatever therapy you want. Obviously, they recommend that metformin, if appropriate, be used early. And then if your hemoglobin A1C is greater than 9%, you do have 2 choices, depending on how symptomatic the patient is. If the patient has no symptoms, it just comes in with an abnormal hemoglobin A1C, you could consider early triple therapy, still using orals, or in the case of the GLP-1 and injectable. Or if they're very symptomatic in terms of polyuria, nocturia, infections, losing weight very rapidly, then the recommendation would be that you start insulin, control the glucose so that you take away the glucotoxicity, and then slowly transition them to the oral agents. And in a lot of cases, after starting insulin, taking away the glucotoxicity, establishing control, a lot of these patients are able to go on to oral therapy without insulin over a period of 3 to 6 months. This, I said, this is a very practical approach based on hemoglobin A1C, and I feel that that's very appropriate. The other issue that the ACE does is that they tell you which drugs are going to prove of great benefit with a green background, and drugs that might prove of some caution with an orange background. And some drugs with the orange background could really end up becoming quite problematic in terms of weight gain or, more importantly, hypoglycemia. And so I think this one table helps very much in trying to put a perspective on all the medications available. As you know, chronic kidney disease is divided into 5 stages, where the stage 1 is there is some evidence for kidney damage, but the GFR is either hyperphysiologic or normal. So the GFR is greater than 90, but you have some evidence for kidney damage. Stage 2 is there's a mild decrement in GFR, where the estimated GFR is between 60 and 89 mils per minute. Moderate or stage 3 CKD is an estimated GFR less than 60, and stage 4 is less than 30, and stage 5 is really kidney failure, and an eGFR less than 15. So that makes it very simple. It makes it easy for us to think through the association of the importance of the kidney function with the importance of trying to establish good control of the diabetes. As you know, the natural history of diabetic nephropathy is basically that you start off with a GFR. Initially, when your glucoses are really high, you might have a supraphysiologic GFR. The osmotic diuresis, the high levels of glucose in the efferent tubule drops the pressures in the efferent tubule. The efferent tubule remains the same, and so you will get an increase in glomerular filtration rate. This is usually over time, slowly comes back to normal and then starts to fall below normal. And in those individuals predisposed to develop chronic renal disease, you will start to see a decrement in GFR over time. Most often, this is associated with the presence of microalbumin in the urine, and as you can see, somewhere after 10 years in those individuals likely to develop clinical significant CKD, you start to see the presence of albumin while you still have a normal GFR. Then as your albumin excretion increases, your GFR decreases in tandem. The pathophysiology of diabetic nephropathy, which really does develop in 20 to 40% of patients with diabetes and is really the most common reason for end-stage renal disease and dialysis in the U.S., is outlined in this slide. The mediators of glomerular damage in diabetes is, in fact, hypertension. The renin-angiotensin-aldosterone system, or the RAS system, is a very important contributor to the progression of disease, and therefore anything that attempts to treat that system is been proven to be of great benefit in terms of protecting from progression of diabetic nephropathy. Reactive oxygen species plays a role, inflammation plays a role, and clearly this is also going to be affected by the presence of ACE inhibitors. And then advanced glycosylation end products, the fact that glucose will tend to glycosylate protein and thereby change the nature of the protein, the rate of degradation of the protein, the rate of synthesis of protein, and therefore change its functional parameters within the organ system. Obviously, majority of these mediators of these glomerular damage is going to manifest as microalbuminuria, subsequent proteinuria, and finally a clear rise in serum creatinine, as I showed you in the slide before. This progression can be slowed and has been clearly shown to be slowed by optimal blood pressure control and optimal blood glucose control. In the UK PDS, it was shown that the rate of progression to diabetic nephropathy was significantly ameliorated by the presence of good blood glucose control, especially initially in the diagnosis of diabetes, and more importantly and much more effectively, the control of blood pressure superseded even the control of blood glucose in trying to slow down the progression to clinical nephropathy. In the STENOS-2 study, which was a wonderful study, small, done in only about 160 individuals, which basically set out to control all the risk factors that you could think of, including blood pressure, diastolic and systolic, cholesterol, blood glucose, weight, it was found that the intensive control of all of those factors really had a tremendous magnifying benefit, and you were able to decrease the cumulative incidence of any cardiovascular events by a phenomenal 58 to 59%, just by the institution of intensive therapy for all the factors involved in the process. So, in conclusion, CKD does occur in about 20 to 40% of patients with type 2 diabetes. It has been shown that early glycemic control soon after the diagnosis of diabetes is effective in decreasing the development and early progression to nephropathy. Blood pressure control is even more important in delaying progression, And the renin-angiotensin-aldosterone system blockade proves of great additional benefit, especially in proteinuric patients. So now let's talk about glycemic control in chronic kidney disease. The goal of control does not change. It remains at less than 7%. Therefore, there is no reason to change the goal. If you are using insulin or agents that cause hypoglycemia in a particularly predisposed individual who has lots of macrovascular potential for complications, you are going to change the goal and maybe allow a hemoglobin A1c of 7.5% or even 7.8% in those with severe hypoglycemia unawareness. Now, as we consider the treatment options for patients in chronic kidney disease, you always have to look at the additional challenges that many agents have not been studied in these conditions. Many agents may be contraindicated, and there is the higher potential for hypoglycemia in these individuals, and therefore agents that can cause hypoglycemia need to be very significantly monitored and used with great caution. So here's question 1. Metformin is contraindicated in chronic kidney disease when the GFR is less than 60 mils per minute, because metformin is metabolized by the kidney, because metformin accumulates in the blood in patients with CKD, or because the associated acidosis of CKD disrupts hepatic metabolism of metformin. I'll give you a few seconds to put in your answers. And so here's the answer. And basically what happens is that metformin accumulates in the blood in patients with CKD, mainly because metformin is excreted renally. The other issues that are outlined in the options we'll go through in the next few slides. So, as I told you, both for American Association of Clinical Endocrinology and for the ADA, the first-line therapy is metformin. And metformin is normally eliminated unchanged in the urine. The serum half-life of metformin is about 6 to 7 hours. The blood half-life is 17 to 18 hours, mainly because metformin tends to pool in red blood cells, and they act as a reservoir. The FDA has laid out absolute contraindications in terms of metformin in renal dysfunction. If the serum creatinine exceeds 1.5 milligrams per deciliter in men or exceeds 1.4 milligrams per deciliter in women, there is an absolute contraindication for metformin. This was established because of a fear of lactic acidosis. And as you know, lactic acidosis can carry up to a 50% mortality when it is induced by metformin. I think one needs to understand that the eGFR has never been used as a guide whether metformin can be used in the U.S. or not. NICE, which is the FDA equivalent in Europe, actually uses eGFR, and they have much laxer restrictions on metformin. They do say that you use with caution if the eGFR is less than 45 mils per minute, and discontinue if the eGFR is 30. Therefore, they would recommend that you can use it with caution in CKD patients stage 3 and cannot use it beyond, while the FDA would particularly say that we cannot use it in CKD 3 patients. In summary, at low GFRs, we cannot use metformin. The point of discontinuation of metformin is under discussion, but in the U.S., I've told you the cutoffs. In the patient that I presented with a serum creatinine of 1.53 in a male individual with proteinuria, metformin would be contraindicated. I think it's important to keep that in mind. But it's also important to mention that metformin has a phenomenal protection and a phenomenal ability to be used. And therefore, you do really need to be very sure that you cannot use metformin before discounting its use. So we go to the concept of the second-line anti-hypoglycemic agents. Part of the reason why I put first line and second line in quotes is because this is an artificial insurance economic-based distinction. Type 2 diabetes is caused by two specific phenomena among a whole lot of other pathophysiologic drivers. One is insulin resistance and the other one is beta cell dysfunction. To treat one without treating the other is really incomplete therapy. But because of economics and what we've been taught to do with regards to how to treat people, starting slow, going low, we start with metformin that only treats the insulin resistance, and we hope that by doing that, we will allow the beta cells to re-equilibrate and compensate for the dysfunction. Most of the time, the beta cells can do it. A lot of times they cannot, and you need some help with the beta cells. So when you look at these so-called second-line agents, you've got the sulfonylureas, glyburide, glimepiride, glipizide. In countries other than the U.S., Gliclazide. The meglitinides, which are also secretagogues, netaglanide or apaglanide. The incretins, which is basically the receptor agonists, which are the injectables, exenatide, extended-release exenatide, liraglutide, albiglutide, dulaglutide. Or the DPP-4 inhibitors, which are oral agents, sitagliptin, sexagliptin, linagliptin, or alogliptin, and in countries outside the U.S., vildagliptin. We have bile acid sequestrants, colesevelam, the ergoline diuretics, which is quick-release bromocriptine, the alpha-glucosidase inhibitors, acarbose and miglitol, the new one on the market being the SGLT2 inhibitors, and of course, our dear friend, the thiazolidinediones, mostly pioglitazone nowadays, and finally, and absolutely insulin. So, question 2. Which of these insulin secretagogues is appropriate for use in chronic kidney disease? Glyburide, glipizide, glimepiride, repaglanide, or netaglanide? Give you a few minutes to answer the question. And you see here that, in fact, glipizide is the only one that is appropriate for use in chronic kidney disease. Why? Because all the sulfonylureas, with the exception of glipizide and gliclazide, which is not available in the U.S., are mostly renally excreted. Not only that, but their metabolites are active and are also renally excreted. Thus, there is a very high risk of hypoglycemia when you can't excrete these drugs appropriately. Furthermore, the drug causes insulin release irrespective of the ambient glucose. Thus, whatever your glucose is, you will cause the release of insulin, and therefore the risk for hypoglycemia becomes very high. The reason why glipizide is preferred is because it has mainly a hepatic elimination and its metabolites are inactive. Gliclazide is renally excreted but has inactive metabolites. The risk of hypoglycemia is highly associated with sulfonylureas, and more troublesome is that it can be severe and prolonged, mainly because the drug induces insulin release. Insulin then stays around because it is also renally excreted, therefore you get a hypoglycemia. If you treat this with glucose, then it causes a further release of insulin and therefore perpetuates the hypoglycemia. And that's why people coming in with sulfonylurea-induced hypoglycemia, in fact, have to stay in hospital for a longer time. They have to be given the glucose and then slowly tapered off while waiting for the effect of the drug to dissipate from the system. Fatality rates can be as high as 5 to 7%. There's permanent neurologic sequelae in about 1 to 16%, and this requirement, as I've indicated, can take several days. In addition, since patients with CKD also have some degree of malnutrition, some degree of liver dysfunction, may have some alcohol problems, or have acute illnesses. All of these are further reasons why we get into trouble with sulfonylureas. In our patient, the significant risk for hypoglycemia and weight gain is really quite constant, and therefore one should not consider this very early in the treatment of this patient's diabetes. The meglitinides facilitate glucose-stimulated insulin secretion. They're similar to sulfonylureas but have a significantly shorter duration of action. However, the risks of hypoglycemia are increased in CKD, and some of them can be used with declining GFR, but the two agents that are available are not equally affected by renal impairment. Nitaglinide is oxidized in the liver, and the active metabolites accumulate in renal dysfunction, and therefore you will get some degree of hypoglycemia. Repaglinide is also oxidized in the liver. Its kinetics are not altered as significantly, and so it is the more preferred of the two agents. However, it does have some risk of hypoglycemia. So in our patient, there can be safer alternatives to these agents available for use, and we may not use them until we are forced to. That brings us to the incretins. And as you know, the incretins have taken the diabetes world by storm. The incretins are agents that were defined because when when an individual is given an oral load, their ability to secrete insulin is significantly enhanced as compared to an equivalent glycemic excursion induced by an IV glucose load. So in the graph on the left, in the patient without diabetes, you see that the blue line tells you how much more insulin you produce by the presence of the oral load as opposed to the IV load. In patients with type 2 diabetes, similar experiment, you see on the right side that there's marked diminution in the incretin response. In this particular slide is a very important picture. These individuals had type 2 diabetes, were given a placebo, and you notice that over a 4-hour period, the sugar fell a little bit. The insulin didn't do very much, and the glucagon remained tonically elevated. When given a native GLP-1 infused, because this has a very short half-life, you see very quickly that the glucose falls. The insulin goes up, subsequently comes down. The glucagon suppresses, subsequently comes up. That final hour and a half to 2 hours is really, really important, especially in the context of the chronic kidney disease. Notice that when the glucose comes down to close to normal, 90, irrespective of the presence of the GLP-1, which is continuing to be infused, you see a decrease in insulin and an increase in glucagon. No risk of hypoglycemia. The control of insulin secretion is maintained by the ambient glucose, not by the presence of the medication or the hormone. Furthermore, it has been shown that the GLP-1s and the DPP-4 inhibitors, in this particular slide, the DPP-4 inhibitor MK0431 analog, which turned out to be sitagliptin, has specific effects on improving the architecture of the islet. You notice a non-diabetic islet on the far right, you notice a diabetic islet on the far left, and in the middle you see how the architecture, which was disrupted in the diabetes by the glucagon red cells coming into the center of the thing, the green in the center of the islet, the green cells, which are the insulin cells, becoming depleted. You see the recovery of the green cells and the reestablishment of the architecture by the rosary formation of the red glucagon-producing cells. So in fact, these agents not only improve insulin secretion, but they seem to potentially stop the progression of dysfunction of the islet structurally. The DPP, as you know, GLP-1 is secreted in the K cells of the ileum and is rapidly degraded by the presence of an enzyme called dipeptide peptidase 4, DPP-4, and this rapid degradation obviously gives this a very short half-life. However, if you stop the degradation, you can increase the endogenous GLP-1 by about 3-fold in terms of amounts. In this particular study, which is telling, they took individuals with recent onset of hyperglycemia, possibly stress hyperglycemia, following an acute MI, and randomized them to either sitagliptin or a placebo for 12 weeks. Notice that the number of people left with diabetes at the end of 12 weeks was significantly less in those individuals on sitagliptin. Of course, you're going to say, well, they were being treated. What do you expect? When you looked at the oral glucose tolerance test, pre and post sitagliptin, there was really a normalization of the oral glucose tolerance, as shown in the green on the left, and the fact that the insulin profile was no more normalized. Again, they were treated, so what's new about that? But this is a telling part of the experiment. You did an IV glucose tolerance test, and you found that you were able to reestablish the first phase of insulin secretion. As you no doubt know, the first phase of insulin secretion is the first thing the beta cell loses as it starts to become malfunctional. Therefore, if you can reestablish the first phase of insulin secretion, you truly are changing the functionality of the beta cell, making it much more closer to normal, and therefore having a tremendous ameliorating effect. So not only does it have an effect potentially in terms of structure, but it also has a phenomenal effect in normalizing functionality. Therefore, these agents are very powerful. If you look at the comparative efficacies of all of these agents, elagliptin, linagliptin, sexagliptin, sitagliptin, or vildagliptin, it is almost exactly the same. And you can quibble about 0.1% one way or the other, but they all give you about the same reduction in hemoglobin A1c. They're all completely weight neutral, because in fact insulin is only secreted in response to glucose, and basically therefore you don't have any extra insulin to be able to put away fat. Now, when you look at them in terms of chronic renal disease, sitagliptin, sexagliptin, and elagliptin are all predominantly cleared in a renal fashion. Therefore, they all require dose adjustments if your creatinine clearance is less than 50 mils per minute. If you look at the study looking at sitagliptin in chronic kidney disease, you clearly showed that even at the lower dose, you still showed equivalent benefit. This was the same that was seen with sexagliptin, it was seen with elagliptin. What the message is that when you have to cut the dose because of the renal dysfunction, you do not lose any potency. You still have equivalent potency to full dose in patients with no CKD. I think that's a very important point to keep in mind. Linagliptin is the only approved oral agent as single strength once daily. Its pharmacokinetics are very favorable in patients with CKD. It has minimal CYP metabolism and almost no renal elimination. It's primarily excreted unchanged in the stool, and therefore there are no dose adjustment requirements at all. It's important also to point out that while that is in fact a clear advantage, the lower doses of the other agents, as I've already told you before, do not lose any efficacy in terms of by cutting down the dose in patients with CKD. So they're equivalently potent. Now what about the GLP-1 agonists? GLP-1 agonists are injectables, and they can be divided into two, the mimetics and the analogs. The mimetics is exenatide, which has about a 50 to 60% homology with native GLP-1, and the analogs are, in fact, minor alterations in the native GLP-1 molecule so as to cause long-acting or the ability to last in a long-acting fashion. And the analogs are liraglutide, albiglutide, and dulaglutide. When you look at what GLP-1 agonists do, they acutely improve the beta cell response in type 2 diabetes. Here you see that in individuals in blue treated with placebo, the sugar fell over 8 hours minimally, while the addition of either the lower dose or the higher dose of exenatide gave you a very significant quick response in terms of plasma glucose, which was because of the superb effect it had on insulin secretion. These results, while shown for exenatide, can be completely the same for exenatide long-acting, for liraglutide, or any of the other weekly formulations. So I don't think there's any difference in their responses. When you look at glycemic control with the GLP-1s, there has been a lot of head-to-head comparisons, and almost always liraglutide comes out a bit better or about equal. But overall, you're still quibbling about 0.2 to 0.3% changes in hemoglobin A1C on average. And so they all are effective and are clearly very appropriate. Albiglutide, just to be absolutely clear, the other ones didn't show. Albiglutide shows the same response as does dulaglutide. And so what I'm trying to basically say that, in effect, they're all very comparable. The hypoglycemic risk with GLP-1 receptor agonists is very, very low. As I said, GLP-1s induce or allow the beta cell to release insulin, but only in response to the ambient glucose. So that if the ambient glucose is clearly normal, there is no reason to produce insulin, the presence of the agent does not constitute a reason to produce insulin. So in a meta-analysis of 15 trials with exenatide, liraglutide versus comparators or placebos, the risk of hypoglycemia was very low, except if it was used in combination with a sulfonylurea. The sulfonylurea causes the unrestrained release of insulin and therefore increases the risk of hypoglycemia. Head-to-head trials, I've already mentioned, again, significantly less minor hypoglycemic episodes with these agents. And between them, there's maybe a mild difference, though I don't know that that's statistically significant. Again, major hypoglycemic events occur if you add a sulfonylurea or insulin to the mix. The weight effects of these agents is remarkable. All of the GLP-1s are associated with an equivalent amount of weight loss, as you see between 2 and 2.4 kilograms, depending on which study you see. And they're basically similar. You might have statistical significances, but clinically, there are no differences in the amount of weight that's lost between all these agents. And so certainly all of them have the same benefit. They also have significant benefits in terms of blood pressure and lipid changes, and a meta-analysis of all of these shows clearly that there is a significant drop in blood pressure, a drop in cholesterol, a drop in LDL, and some drop in triglycerides. So clearly these agents have all of the ameliorating effects to the metabolic syndrome that we like to see. Exenatide in the CKD patient becomes a little bit of a problem because it is predominantly eliminated by glomerular filtration. So up to a creatinine clearance of 50 mils per minute or greater, you can use it without dose adjustments. You need to escalate downwards with the creatinine clearance between 30 and 50, and it's not recommended if the creatinine clearance or eGFR is less than 30. Again, the risk of hypoglycemia does increase, especially if it's used in sulfonylureas, and there has been some renal impairment that has occurred in patients who are complaining of nausea, vomiting, and diarrhea without dehydration when using the exenatide. So the FDA statement is in quotes below, should not be used in patients with severe renal impairment or end-stage renal disease, and should be used with caution in patients with renal transplantation. And obviously, the caution should be applied when initiating exenatide or escalating the dose in moderate renal dysfunction. The same thing stands for extended release exenatide, the weekly injection, and I don't need to repeat the caution as it's outlined there. Liraglutide has some caution with regards to creatinine clearance is less than 60, but a 2011 meta-analysis found there was no difference in efficacy with mild renal impairment. There was a reduction of cardiovascular risk factors, as I showed you, even in patients with mild renal impairment. And severe renal impairment was associated with increased incidence of nausea, but not necessarily significant in terms of dehydration. There was a recent paper just last month that also underlined the same mentions with liraglutide. So the FDA's position still remains as limited experience in patients with mild, moderate, and severe renal impairment, including end-stage renal disease. There have been post-marketing reports of acute renal failure and worsening of chronic renal failure, which may sometimes require hemodialysis, so therefore liraglutide should be used in caution in this patient population. No dosage recommendations are recommended for patients with renal impairment. So, when you think about GLP-1 use with renal impairment, you have to remember that albiglutide, exenatide has a significant contraindication if your creatinine clearance is less than 30, but the analogs, albiglutide, liraglutide, dulaglutide, can be used with caution. So, in summary, GLP-1 receptors have a variable effect. Exenatide and exenatide ER should not be used in CKD4. The dose of exenatide immediate reacting must be escalated with great caution when you have a creatinine clearance between 30 and 50. Liraglutide can be used with the usual degrees of caution, and the same thing with the newly licensed one-weekly analogs. So in our patients specifically, a GLP-1 analog may be an appropriate choice to use early on in the process of the disease, not only because of its ability to give you control, also its ability to get some weight loss, and most importantly, the ability to improve the other risk factors, hypertension as well as dyslipidemia. Bile acid sequestrants, cholesterol lowers hemoglobin A1C by 0.5. It's not associated with weight gain or hypoglycemia. It is minimally absorbed from the GI tract and therefore requires no renal dosing adjustments. But it hasn't got a powerful enough effect, so it would be an appropriate adjunctive therapy in patients with CKD and hypercholesterolemia, as is our patient. Please remember that bile acid sequestrants can elevate triglycerides. So if you already have a high level of triglyceride, you have to use bile acid sequestrants with great caution because triglycerides may elevate very significantly. The quick-release bromocriptine, the mechanism of action in diabetes is unknown. We know that changing the neuroendocrine circadian rhythm can affect insulin sensitivity. This has been shown over and over again in hibernating animals and clearly has some effect in humans. It is associated with about a 0.4 to 0.6% drop in the hemoglobin A1C. Only the quick-release bromocriptine is approved for treatment in diabetes. You cannot use the general bromocriptine that would be used to treat prolactinomas. This is quick-release bromocriptine. It has to be taken within the first 2 hours of awakening in the morning, and it has kinetics that are favorable in CKD, about 5% renal excretion, 85% fecal excretion, not associated with hypoglycemia. It doesn't cause a release of insulin. So again, just because of its ability to lower hemoglobin A1C in a limited fashion, it's a very good adjunctive medicine, but not necessarily the primary medicine for our patient. Alpha-glucosidase inhibitors, acarbose and miglitol, these have not taken off in the United States as much as they've taken off in the rest of the world. Acarbose has a bioavailability of 34%, and its metabolites are renally excreted. So in patients with CKD4, acarbose can increase, the levels of acarbose can increase 5 to 6-fold. There are case reports of hepatotoxicity. We don't know if the renal failure affects this risk. Miglitol has a variable bioavailability and is almost exclusively renally excreted. The half-life increases significantly with declining GFR. The consequences are known. So therefore, both agents tend to accumulate in renal impairment, are contraindicated with a serum creatinine greater than 2 milligrams per deciliter. These agents would not be recommended in our patient, and I suspect he might have some difficulty tolerating it, just from the point of view of the increased flatulence that these agents are associated with. Thiazolidinediones have had a very bad name. They have multiple concerns not unique to chronic kidney disease, heart failure, fractures, bladder cancer. The risk of heart failure is further increased if you have CKD, but not if the patient is on dialysis, because once the kidney is non-functioning, the ability of the TZDs to cause fluid retention is markedly diminished. And so therefore, dialysis is different from CKD. Obviously, the risk of heart failure is increased if it's used in conjunction with insulin or if they've had previous MIs and some degree of cardiac decompensation. The fracture risk may be of some concern in patients with CKD in the setting of associated renal bone disease. And while renal dosing is not necessary, these agents are a little problematic in this circumstance where people have some significant cardiovascular associated morbidity and therefore should be used with great caution. The SGLT2 inhibitors are the new people on the market. They work by inhibiting the SGLT2 receptor in the proximal tubule in the kidney, responsible for reabsorbing the glomerulally filtered glucose. They lower hemoglobin A1C by about 1%, are associated with weight loss and a decrease in blood pressure. There is an increased incidence of lower urinary tract infection, especially mycotic infections. It is not indicated in CKD if the creatinine clearance is less than 30, and it should be used with caution in people with creatinine clearances between 30 and 50. Again, in our patient, this would be a nice adjunctive agent, probably not a primary agent. Insulin obviously is insulin. It, however, does have severe changes in kinetics in CKD. As you know, insulin is renally eliminated up to 50%. Time to Cmax is prolonged in CKD because it has a prolonged serum half-life, and the rapid-acting formulations are obviously less affected than the basal insulins. The problem here is acute changes in renal function necessitate increased blood glucose monitoring because that changes the metabolism or the elimination of insulin. And so therefore you have to keep this in mind. And pumps may have to be preferable to injections in such individuals, mainly because they're getting a lower dose of overall insulin at any one time and therefore are much less liable to accumulate this. Recommendations, general recommendations for adjusting insulin as the creatinine clearance declines. If your creatinine clearance is between 10 and 50 mils per minute, you might want to reduce the dose of insulin by about 25%. If the creatinine clearance is now less than 10 mils per minute, you probably do need about a 50% decrease, and dialysis patients may require less insulin due to decreasing insulin resistance. And also remember that agents or insulin that you would normally say only last 12 hours will last a longer time in such individuals, and that should be kept in mind when you're doing multiple daily dosing. All changes in insulin dose should be accompanied by adequate monitoring. Monitoring in this circumstance is absolutely crucial. And while insulin is thought to be safe, and it is in fact safe, it has to be used very carefully because hypoglycemia can be a very significant and real risk in these group of individuals. So, in conclusion, glycemic goals do not differ significantly in CKD as opposed to patients without CKD. However, using anti-hypoglycemics can be a challenge. The DPP-4s and the GLP-1s are becoming more and more the appropriate choices and the choices of distinction for treating the patients, because they not only treat the hyperglycemia, the abnormal glucose, bring it down to normal, but have the potential to treat cause of the reason, the beta cells, and have the potential that they may change beta cell functionality and therefore slow the progression of the diabetes itself. Has this been proven in humans? No. Has this been proven in animals? Yes. Could we behave like animals at some point in time? I think most of us would say yes at some point in time. Some agents, bromocriptine, the bile acid sequestrants, the glitazones, do not require dosing adjustments, but do have some restrictions. The only sulfonylurea that can be used in severe CKD is glipizide, and it must be used with great caution. It can cause hypoglycemia. Low doses is the way to go. Metformin is contraindicated at any level of CKD over grade 2 in the U.S. There are some nuances of differences among the non-U.S. population. And insulin can be used and absolutely has to be used, but has to be used with great caution, and always keep in mind some significant increase in monitoring. I'd like to conclude there. I hope I've been of some help to you. Thank you very much for your attention, and hopefully this will help you come up with more rational ways to treat patients who have diabetes and chronic kidney disease. Best wishes. Thank you.
Thank you so much, Dr. Mehta, for that insightful look into management strategies in patients with type 2 diabetes and chronic kidney disease. It should be noted that up to 50% of long-standing diabetes patients will suffer from chronic kidney disease. It is clear that ongoing monitoring of renal function and, in particular, the presence of microalbuminuria, that is 30 to 300 milligrams per gram creatinine on random urine testing, must be done. This surveillance provides not only a window into the prediction and prevention of small vessel disease involving the kidney, eye, and peripheral nerves, but also to large vessel disease involving the heart and brain. Although the focus of Dr. Mehta's presentation was on the safety and efficacy of glucose-lowering agents in type 2 patients with chronic kidney disease, it must be emphasized that therapeutic interventions must also focus on control of blood pressure and lipids. Moreover, the addition of agents particularly designed to antagonize the renin, angiotensin, aldosterone system, namely the ACE inhibitors or the ARBs, should also be prioritized. Whether or not chronic renal disease can be ameliorated or prevented clearly depends upon ongoing monitoring and therapeutic intervention. With the advent of renal dysfunction, therapeutic options must be adjusted. In particular, the FDA advises that metformin should be discontinued when serum creatinine rises above 1.5 milligrams per deciliter in men and 1.4 milligrams per deciliter in women in order to avoid the rare complication of lactic acidosis. I would predict that, in light of recent reviews on the subject and advice from our European and Canadian colleagues, that these stringent FDA-engendered rules will be relaxed in the future. As discussed by Dr. Mehta, the preferred drug in the sulfonylurea class to be used in patients with compromised renal function should be Glipizide. Regardless, sulfonylurea doses should be reduced or their use discontinued when serum creatinine rises above 2 to 3 milligrams per deciliter in order to avoid the serious risk of hypoglycemia. Dosing of the DPP-4 inhibitors on the market, with the exception of linagliptin, needs to be adjusted downwards in the face of progressive renal dysfunction. Moreover, the use of GLP-1 agonists must be used with discretion and caution in this circumstance. Lastly, if chronic kidney disease progresses, the ongoing conjoint care of the patient with a nephrologist is highly recommended. This will help with blood pressure control as needed. More importantly, it will assist in prevention of progression of the disease and to plan for and intervene with dialysis when appropriate. In closing, on behalf of myself, Dr. Adi Mehta, and the Cleveland Clinic, thank you for attending this fourth session in our fourth season on Virtual Grand Rounds on Diabetes.